So basically, today inshallah we'll go quickly over mechanism of arrhythmias in general. What I want you to know is just the name of these mechanisms. I'll explain it briefly. I don't spend much time, so we can concentrate on the cases itself. We'll go quickly over clinical presentation, basic management of tachyarrhythmias, differential diagnosis of narrow and wide various complex tachycardia in different cases. So, automaticity, we know this is one of the mechanisms of tachyarrhythmia. About 10% of arrhythmia is due to abnormal automaticity. Automaticity means ability of the cell to depolarize spontaneously. Normally, this is the function for the sinus node. The sinus node fires by itself without stimulation. The rest of the heart, like atrial tissue, AV node, ventricular tissue, need to be stimulated. So normally, it does not have automaticity. If abnormal automaticity happened in the atrium, it will cause atrial tachycardia, or in the junctional area, it will cause junctional tachycardia. In the ventricle, it will cause ventricular tachycardia. And of course, this abnormal automaticity has to be faster than the sinus node. If it is not faster than the sinus node, we will not see it, because the sinus node will be controlling the heart. So this is an example of it. Ectopic atrial tachycardia, multifocal tachycardia, or ventricular tachycardia. There are certain factors that cause this abnormal automaticity, like increased sympathetic activation composite, decreased parasympathetic, acidosis, hypoxia. There are different mechanisms that can trigger abnormal automaticity. Second one is called triggered activity. We know normally action potential has depolarization, then repolarization phase, and goes down to the baseline. If during repolarization we have a depolarization, and that depolarization trigger another depolarization, and trigger another depolarization, and another, that's why it's called trigger, it will produce tachycardia. This is a specific type with usually polymorphic VT is produced by this mechanism, abnormal activity due to triggered activity. It could happen in phase 3 called early, phase 4 called delayed. Again, just remember the name. Remember, triggered activity is a mechanism of tachyarrhythmias, not bradyarrhythmias. The third mechanism is re-entry. And about 80% of tachyarrhythmia is due to re-entry. 10% abnormal automaticity, 10% triggered activity. So just imagine this is an AV node, and we'll discuss that it could happen actually the re-entry in the atrium, it could happen in the ventricle, and other parts of the body. So normally, the AV node has one conduction only. So from atrium to the ventricle, only one conduction. In about 10 to 15% of the people, they have abnormal connection, another one called slow pathway. So they have two pathways. And to have these two pathways separate, there must be something separating them anatomically or physiologically. So no conduction in between. So this pathway is conducting by itself, and this pathway is conducting by itself. They don't communicate in the middle. And the refractory period has to be different. If the refractory period is the same, we cannot have any tachycardia, because if the impulse comes and blocked in the two pathways at the same time, we will not have any re-entry. So it has to be one faster conduction, one slower conduction. One has longer refractory period, one has shorter refractory period. So under normal circumstances, impulse comes from the atrium, we have a P wave, it goes down the AV node to the ventricle, so we have the normal PR interval, which is 3 to small boxes, right? 120 to 200 milliseconds. If the patient like this has slow pathway, and impulse comes prematurely, so it comes when the fast pathway now did not recover yet, it's still refractory. It is not conducting down the fast pathway, it goes down the slow pathway. If by the time it reaches here towards the ventricle, this is still refractory, nothing will happen. I mean, it cannot go back up again. But what will happen to the conduction from atrium to the ventricle? Will it be the same or longer? Longer, because this conducts slowly. So the PR would be longer than normal, but no tachycardia. So fast pathway, short PR. Blocked in the fast pathway with premature beat, down the slow pathway, we will have long PR intervals. So what will happen if we have another mechanism that premature beat blocked in the fast pathway? It goes down the slow pathway. When it reaches this area, with the junction between the two towards the ventricle, the fast pathway recovered. Now able to be excited again. And it stimulates the fast pathway and go up the atrium and re-enter back the slow pathway. So start re-entry. Goes slow, fast, slow again. Slow, fast, slow again. And when this fast circuit is there, it stimulates the atrium and the ventricle almost simultaneously. So it goes to the atrium, goes to the ventricle, atrium and ventricle. This is starting the mechanism that we call re-entry. So block in the fast, down the slow, up the fast again, and it continues to happen quickly. So the circuit is fast and activate the atrium and the ventricle at the same time. This is called re-entry. Again, re-entry is commonest mechanism for arrhythmia. We see it typically in the AV node. In the Parkinson-White syndrome, we have AV node and accessory battle can cause re-entry. If there is scar tissue in the ventricle, and the scar tissue is dead tissue, does not conduct, and we have area of slow conduction, area of fast conduction around the scar, premature VVC can start the re-entry. So that's why re-entry is not only in the AV node, it can happen anywhere, but it's explained it to be easier in the AV nodal area. And okay. So what if a patient has tachycardia, rate is 121, what usually symptom they will present with? Palpitations, it's not the commonest. They may have shortness of breath, chest tightness, then they may have start to have more symptoms like dizziness, pre-syncope or syncope, less common, but this can happen, the actuaries notice. Very rarely they may present a sudden death in patients with VTVF, they may present with sudden cardiac death. Right? Parkinson-White syndrome, very rarely if they have atrial fibrillation conducting very fast, they can present with sudden death. But the common is common, just shortness of breath, chest tightness, fatigue, palpitations. Then less common, they may go to syncope, pre-syncope, or rarely sudden cardiac death. How to manage? Initial assessment, look to the symptoms. If somebody has shortness of breath, chest tightness, totally different from patient who's having severe chest pain, or a patient who can mentally is not normal and cannot respond even to your question, or about to lose consciousness, or a patient with syncope. So symptoms is important. Vitals, if the patient hypotensive is totally different from normal blood pressure and normal exam. And remember, obtain 12-lead ECG as early as possible to get the diagnosis, IV access for medication delivery. Then based on this initial assessment, which should be quick, we determine if the patient is stable or unstable. Unstable patient, if they have altered mental status, if they have hypotension, severe persistent chest pain, or if they have acute shortness of breath, or hypoxia. If one of this is there, we are dealing with emergency and the patient is unstable. If not there, we are dealing with stable patient and we have time to go for the next one. For unstable, follow the ACLS protocol, Advanced Cardiac Life Support Protocol, and in this protocol you maintain the ABCs, airway, breathing, circulation, while preparing to shock the patient to cardioversion back to normal. Any fast tachycardia, hemodynamic instability, we don't wait, even if you don't know the diagnosis. You just go and try to save the patient first, and then look what is the cause of it. So ACLS protocol and shock the patient. If it is ventricular fibrillation, it will be defibrillation. If it is narrow QRS complex or monomorphic VT, it will be cardioversion. So this is the difference between the two. Now, if the patient is hemodynamically stable, you have your time to take the history, do exam, do the investigation, look what is the cause, and then manage accordingly. What is the diagnosis, and manage based on sinus tachycardia different from atrial tachycardia, different from atrial fibrillation, different from atrial flutter. So this is overall basics of management. Now, when it comes to the diagnosis, generally we look to the rate, QRS complex width, and rhythmicity. This gives you the differential diagnosis with the patient in emergency. So, of course, for tachycardia, the rate has to be above 100, right? So more than 100, the patient's tachycardia. QRS complex width could be narrow or wide. Now we have differential diagnosis. Wide, we have another differential diagnosis. Regular, different differential diagnosis from irregular, right? So that's why you keep it in your mind. What is the rate? Is it narrow or wide, regular or irregular? Then we will come to next step, which is the P-width. So if the patient is tachycardic, narrow, think about sinus tachycardia, supraventricular tachycardia, atrial fibrillation, atrial flutter. This is overall, regardless of regularity or irregularity. Wide, think about VTVF. Now, we'll just make it narrowed further. So if it is narrow and rate is above 100 and it is regular now, so what's the possibility? What's the possible diagnosis? A patient in emergency room is tachycardia, narrow and regular, sinus tachycardia number 1. Remember regular. So that's why we differentiate now between regular and irregular. Irregular will cause atrial fibrillation, right? But regular, supraventricular tachycardia. Remember, all SVTs are regular. Supraventricular tachycardia, atrial flutter could be regular. So with regularity, we narrowed our differential diagnosis to this. Irregular, atrial fibrillation. But it is narrow, so that's with ventricular fibrillation we are talking about supraventricular rhythm. So atrial fibrillation, atrial flutter with variable conduction, or multifocal atrial tachycardia. And actually, most of the time when we see irregular, we just think about these three things. If it is regular, we have a little bit longer list of differential diagnosis. If it is wide, of course, you think about VT or VM, so that's a little bit limited. Now, we'll do it as cases. So we'll start with this patient who is 35, female, and she has palpitations. What is your ECG interpretation?
The rate is 140.
About 130, 140, isn't it? So tachycardia. Regular. Narrow or wide? Narrow. Regular or irregular? Regular. So what is our differential diagnosis? Sinus tachycardia or SVT or flutter with regular conduction, like 2 to 1 or 3 to 1. Do you see next step is to look for P wave? Is there a P wave here?
Yes.
Okay. And is it constant before each Keras complex?
Yes.
The same as sinus P wave in lead 2 and 1, upright in those two leads?
Yes.
So it is upright. So we know from this ECG that the patient is tachycardic, it is narrow, it is regular, and we have P wave before each Keras complex, similar to what you expect from sinus node. So this is sinus tachycardia. So rate usually is above 100, and most of the time the sinus tachycardia is for physiologic responses. We can discuss in a minute. But there are some pathological diseases that can cause it. So what are the physiologic causes of sinus tachycardia? The commonest one, exercise, and anxiety, stress, it can cause it. Certain medication can cause it physiologically. Pathological causes like fever, hypotension, hypoxia, congestive heart failure, bleeding, anemia. We call sinus tachycardia in this case, it's called reactive sinus tachycardia. Actually, it is not pathological, it is helping the patient, because if somebody is hypotensive, increase the rate will increase the cardiac output, so it's a compensatory mechanism. Same for patients with infection, fever, metabolic demand increases, so we need to increase the cardiac output, the heart will increase the rate to compensate for that one. So in these cases, we don't treat the sinus tachycardia, we treat the underlying disease, because actually it is in part, it's important for the patient, you don't block it at this stage. So, sinus tachycardia, if it is physiologic, of course there is no treatment with exercise normal. And if there is pathologic disease, treat the underlying pathology for reactive sinus tachycardia. In rare situations, we call it inappropriate sinus tachycardia. If somebody at rest, heart rate is 100, 110 without activity, this is not normal, right? If somebody with minimal activity rate goes 140, 150, and they have palpitations, this is not normal, called inappropriate sinus tachycardia. Usually in young female, we treat it with beta blocker, calcium channel blocker. There is a specific medication called Irregular or others. By the way, management, I'm usually just outline, so inshallah in the final year, management will concentrate on it. Now, the most important is just to recognize what it is. Do you know this is sinus tachycardia, this is more than important? And do you know most of the time it's physiologic? We didn't go in details of management, it's just outlined. Now, look to the second case. 75-year-old with palpitations. So let's start with the basics. What is the rate? Heart rate?
Around 140.
Okay. Yeah, about 160, 170, a little bit faster. The second question, is it narrow or wide? Narrow. Third question, regular or irregular?
Regular.
Regular, excellent. Do you see clear P wave before each Keras complex? In this one, you may not say, but look to lead 2. What is this here? What is this here? Yeah, and if you look carefully here, there are P waves. But the next question, is it normal P wave morphology or abnormal? Abnormal P wave morphology. So P wave, it means it's a depolarization. And if the morphology is not normal, it's not coming from the sinus, then activation doesn't from the sinus. So it's coming from the atrium. So tachycardia and source from the atrium, atrial tachycardia, right? It's clear for everybody? Atrial tachycardia. So this atrial tachycardia, why the patient has it? Remember the three mechanisms of arrhythmias? Could be abnormal automaticity in the atrium, could be triggered activity, or it could be re-entry, micro re-entry in the atrium causing this atrial tachycardia. Generally, it can be sustained, it's continuous. Non-sustained, just short period of time. Paroxysmal comes and goes. Or it could be incessant. This incessant means the patient tachycardia most of the time, and just rarely we see 2 or 3 beats of normal. Don't worry about the terminology, but just for your information. The most important to make sure there is a P wave. P wave morphology is different from the sinus P wave, so we are dealing with atrial tachycardia.
On the ECG, could it be the junction of tachycardia?
What is the good question actually? Excellent question. So why it's not junctional?
Because there's a P wave.
By the way, in junction, very rarely, remember 70% we do see P wave.
Yeah.
But rarely we see P wave before chaos complex. The difference between junctional and atrial is the PR interval. Remember, junctional is coming to activate atrium ventricle at the same time. Even if the atrium slightly activated before the ventricle, the PR would be very, very short. Yeah. So if you see P wave, inverted, and very short PR interval, this is junctional, right? But if you see PR within the normal range, 3 to 5 small boxes, it's coming from the atrium, from junctional. How to manage? If it's just brief, no much symptoms, we don't need to do anything about it. If symptomatic, we may treat with calcium channel blocker, beta blocker, digitalis. In refractory cases, difficult cases, we use antiarrhythmic. I'm sure you have it in pharmacology, class 1 medications like flecainide, propafenol, you can use it. Or class 3 sometimes, like sotalol, rarely amiodarone. Again, certain patients, if it is monomorphic and constant and not responding to medical therapy, we can consider electrophysiology study and ablation. So we get catheters inside the body, we induce the tachycardia so we see it, and then we localize where is it coming from, and then try to burn it out by radio frequency. So catheter ablation is another management line. So sinus tachycardia, atrial tachycardia, the main difference is the P wave morphology. Third case, 45-year-old female with palpitations.
So rate is 140.
Yeah, about 150, 140, yeah.
Regular.
Narrow.
Narrow.
Regular.
No P wave.
We don't see clear P wave. Now, with the absence of the P wave, we will narrow our differential diagnosis to a certain group. What is it called? It could be junctional, remember, junctional usually 100, 120. Here is 140,
Yeah.
150. So, supraventricular tachycardia. This is the main thing. So this is supraventricular tachycardia, SVT. This is the baseline ECG for the same patient. You see when the P wave is clear and there. So totally different from the one we saw. Supraventricular tachycardia, by the way, by general terminology, anything activated the ventricle from up down, from the atrium or from the AV node and go to the line is called supraventricular. So this will include, of course, atrial flutter, atrial fibrillation, AV nodal, atrial tachycardia, AV re-entry. However, because atrial fibrillation, atrial flutter, usually you see ECGs, you recognize it easily in emergency. We take them out and we concentrate on 3 things that you cannot differentiate based on ECG. So one is AV re-entry in the atrium. Second, accessory pathway AV re-entry. The third is atrial tachycardia. And then the question comes, we just show sinus atrial tachycardia and we see from ECG we can diagnose it. Right. But in rare situation, if the PR is very long and the rate is very fast, what will happen to the P wave? It is hidden within the T wave.
Yes.
So we cannot differentiate. So we cannot see it clearly. So that's why atrial tachycardia included in the SVT. If you take it as a percentage, this is 60% of the time. This is about 20 to 30% of the time. This is only 5 to 10% of SVT. So that's why this differential, again, atrial tachycardia is part of it, but it is rare actually in SVT, especially in adult. I'm talking about adult population. Children, pathway is more common than AV nodal re-entry. In adult, AV nodal re-entry is more common than pathway. But atrial tachycardia included for special situation when the PR is long and we don't see the clear P wave. It is hidden within the T wave. So still, we will not be surprised if we convert the patient to normal sinus rhythm and discover later that has atrial tachycardia. It is less likely, but it is one of the differentials.
So we call it supraventricular tachycardia when there is no P wave?
When we don't see clear P wave, right? And by the way, it's clear is important because sometimes you see, is it a P wave, it's not a P wave, is it T wave? So if you don't clear P wave, you call it supraventricular tachycardia.
can go back to the previous slide. Aren't there P waves there?
This is the sinus, the ECG of when the patient converted to sinus rhythm. But if you see the tachycardia for the same patient, there is no clear P wave. And actually, the only reason I showed it is to see how the P wave is the baseline, and this is with the patient in tachycardia. Sorry.
So junctional tachycardia is not part of SVTs?
By the way, there is a condition called junctional tachycardia, by the way. We see it in children and adults less likely, but it's very rare, by the way. So we always deal with common as common. And how to differentiate between AV nodal re-entry, by the way, and the junctional tachycardia, which could happen in 150, 160, is a mechanism. Junctional tachycardia is abnormal automaticity. AV nodal re-entry is a re-entry mechanism. We can differentiate in EP lab, because if you see we induce it and there's two pathways, we know that it's AV nodal re-entry. If you see it is automated focus, we cannot induce it, we know this is junctional tachycardia. But the only reason I'm not discussing it because this is less common, and I don't want to, common is common, we will discuss the common, and there are some certain exceptions, of course. So in certain patients, in pediatric especially, they may have junctional tachycardia, and we see that they gradually go up, gradually down, there is no clear P wave, so different from the sinus node. We also demonstrate an EP lab, but this is rare, so that's why we don't discuss it usually this way. So AV nodal re-entry, remember two pathways. In the AV nodal area, one is slow, one fast. Premature B comes, goes on the slow up the fast. This is typical form. Sometimes could be reversed, but this is rare, we'll not discuss it, it's not important. Typically the age is between second and third decade of life. Females more affected than males. Rate is usually 150 to 250 beats per minute. These are just showing cartoon for the AV node with two pathways, one fast, one slow. Wolff-Parkinson-White syndrome is the same thing, but we have what we call bundle of Kent or accessory pathway. It conducts the atrium to the ventricle. It is muscular tissue, and they're born with it. So, and not everybody will have it. So, certain people they're born with this connection called accessory pathway. So, this is the ECG of a patient with Wolff-Parkinson-White syndrome. What do you notice here? What is the main thing in the ECG? By the way, this is if the patient the same tachycardia with terminated tachycardia, and this is the baseline ECG. We have a diagnosis from baseline ECG because what are the features here that suggest WBW or Wolff-Parkinson? Short PR. PR and Kerr's complex very close. Delta wave, you see it very clear here, and wide Kerr's complex. If you have this triad, the baseline ECG after converting the patient from tachycardia to normal, this is Wolff-Parkinson. Or if the patient, we know the baseline ECG is this one, we are dealing with Wolff-Parkinson-White syndrome.
So usually look for the patient has tachycardia, the patient has tachycardia.
With tachycardia, I'll explain now when they have the tachycardia how they present. It will be in a minute. So basically, this is what happened in people with Wolff-Parkinson-White. Normal circumstances, sinus node activate the atria, we have a P wave, right? It goes down the AV node, it's delayed a little bit, so we have PR. Ventricle activated, we have Kerr's complex. This is the normal. If somebody has the pathway, impulse activated the atria, we have a P wave, right? It is delayed in the AV node, right? But this connection is like an open door. So in the lower atrium, immediately it goes to the ventricle. So from lower atrium to the ventricle, the PR would be short because there is fast conduction from atrium to the ventricle. Okay. This part is activated abnormally, red color. Myocardial cell to myocardial cell to myocardial cell. So it would be wide, right? When the AV node now is conducting normally, it goes to the bundle of Hess and Purkinje fibers, rest of Kerr's complex would be normal, right? So we have the short PR because of the conduction through the pathway. We have the delta wave again because of the ventricular activation by the pathway. We have normally the rest of the Kerr's complex. So that is it. So if somebody AV node is conducting very good and fast, the delta wave will be small or big? Very small. And sometimes even we don't see it clearly in the ECG because the AV node is conducting very, very fast, especially young people. If the AV node is not conducting well, you see huge delta wave, right? So that's why delta wave is a function of AV node conduction. If the AV node is conducting very fast, it will be very small delta wave. If the AV node conducting slow, or we give medication that slows down the AV node conduction, the delta wave will be very obvious. Okay, now this is the baseline. So what tachycardia they may have when they have a pathway?
Can you show the delta wave at the ECG?
You see a hump here like a shoulder, P wave, PR short, You see that hump here? And the rest of the Keras complex is normal. That shoulder in the beginning is called delta wave. And that's delta wave. Okay, so this is the AV node. This is the pathway. Normally, we will see the same ECG I showed you earlier. Impulse comes, down the AV node, delayed, some activation of the ventricle, and then back to normal. So just short PR, delta wave, wide Keras complex. What will happen if premature beat comes and the pathway is refractory? It is premature, so it comes when the pathway is already refractory, does not go. And goes down the AV node, activate the ventricle, and up the accessory pathway. So AV node, pathway, AV node, pathway, AV node, pathway. Will it be narrow or wide? Why? Because conduction goes the normal conduction system. Why the Keras complex is narrow? Because the conduction is very fast through the right and left bundles and Purkinje fibers. So it will be narrow Keras complex. And this is 90% of the time. And we call it orthodromic tachycardia. Ortho like normal. So the conduction in the AV node is the normal, because normally AV node conduct this way, from up down, right? So this is called orthodromic. 90% of the SVT, supraventricular tachycardia, because of a pathway, is orthodromic AV node. Think about the other way around. If premature beat comes, the AV node now is not conducting, it's refractory. It goes down the accessory pathway, up the AV node. Accessory pathway, AV node. Will it be narrow or wide? Wide. Why? Because activation is abnormal. Myocardial cell to myocardial cell, and because in the AV node the conduction is opposite the normal, we call it antidromic. So this is orthodromic, this is antidromic. This is narrow, this is wide. This ECG will be similar to the ECG I showed you earlier. The ECG with this condition would be wide Keras complex and differential diagnosis of wide Keras complex. 90% of the time, SVT is orthodromic. 10% is antidromic. So that's why we concentrate on pathway in this way more than this one, because this is the common. So in patients in emergency room with narrow Keras complex, we think it is SVT, supraventricular tachycardia. How to manage? Try to block the AV node by vagal maneuvers. If it is not working, you give IV adenosine. Not working, you may try IV verapamil. If the patient is hemodynamically unstable, what to do? Blood pressure is low. You know, the general rule for tachycardia with hemodynamic instability, ACLS, guidelines, protocol to maintain the ABCs, and shock the patient. Convert into sinus rhythm immediately. We are okay so far? For the AV nodal and for the accessory pathway, radiofrequency ablation in catheter EV study and radiofrequency is very successful, 95% of the time or more. So generally it is first line therapy. If the patient does not want to have EV study and ablation, they go for medical therapy like beta blocker or calcium channel blocker. One exception, by the way, if the patient has antidromic tachycardia, the one which is wide, we should not give beta blocker or calcium channel blocker, we should not give digoxin. The adenosine is contraindicated because if you block the AV node, you are just enhancing the conduction down the accessory pathway. This is exception, and as I said earlier, this is 10% of the cases. So we're talking about common. Common is common. Okay. This is a 65-year-old. So now we finished, by the way, with narrow Keras complex and regular. Could be sinus tachycardia, atrial tachycardia, or supraventricular tachycardia. And supraventricular could be atrial tachycardia with long conduction, or it could be AV nodal or AV reentry tachycardia. Now we'll move to something with the difference here is regularity. What do you think of this? Is it regular or irregular?
Irregular.
Irregular. Narrow or wide?
Narrow.
Narrow. Any clear freeway?
No.
No clear freeway. So we're dealing with
Atrial fibrillation.
atrial fibrillation. So narrow Keras complex tachycardia, the patient is tachycardic here. It is irregular. There is no clear freeway. Our number one differential diagnosis is atrial fibrillation. How about this one?
Irregular.
Irregular.
Narrow.
Narrow. No freeway. So we are dealing again with. What is the difference between this one and the previous one?
Not tachycardia.
Yeah. The first one, remember atrial fibrillation fibrillation, the rate in the atrium is 350 to 500, so the atrium is fast all the time. But the conduction down the AV node, here is conducting fast, so this is called with rapid ventricular response. The second one, the AV node is not conducting fast, this is called with the slow atrial fibrillation with a slow ventricular response. So tachy or brady in the ventricle does not mean that, because some people when say the bradycardia, they will not think of atrial fibrillation. Atrial fibrillation is tachycardia. Yes, there is tachycardia always in the atrium. But if you conduct fast, we call it atrial fibrillation with rapid ventricular response. If it conducts slow, this is atrial fibrillation with a slow ventricular response.
Doctor, in the previous slide, the QRS on lead B2, isn't it wide?
Always measure, because by the way, when you maximize the ECG, sometimes it may look wide. And always we just measure. Is it more than 3 small squares? If I take from here, it is 2 small squares, exactly 2 small squares. So measure it all the time. If you're in doubt, just measure the QRS complex. It looks within the normal.
And also, how did we say it is atrial fibrillation? Because I can't see the P wave.
This is the hallmark of atrial fibrillation. There's no P wave. The hallmark of AFib, atrial fibrillation, the atrium is fibrillated. There is no depolarization or activation of the atrium, so we don't see P wave. And by the way, some people they call this one coarse atrial fibrillation. If you see the baseline, there is some activity, right? And the other one is flat line. It's called fine atrial fibrillation. There is no, you don't see that flat line. There is no activity at all. Both does not mean anything. Just it's both atrial fibrillation. Okay. For atrial fibrillation, so it is disorganized rapid atrial activation. It's the commonest sustained arrhythmia. That's why it's important. It's very common. The rapid ventricular response or rate, it can be predisposed to cardiomyopathy and heart failure. So that's why we manage it early. The other important thing to remember, it can be predisposed to stroke. So in AFib and flutter, prevention of thromboembolic stroke or thromboembolism in general is very, very important. Commonly, we know the rate in the atrium is 350 to 500. It is very fast in the atrium. But the conduction normally, or most of the time, between 110 to 160. And when the rate is above 100, we call it rapid ventricular response. If less than 60, slow ventricular response. The slow ventricular response could be 2 reasons. Number one, if AV node conduction is not normal. So elderly, AV node is not normal. Or if we start to medication that could slow down the conduction down the AV node, it can slow too much, so they went into bradycardia. Beta blocker, calcium channel blocker can slow down the conduction. And some people, they shift from tachycardia to bradycardia. Why they have atrial fibrillation, the underlying mechanism? It could be atrial activity, or like atrial tachycardia, originating from one of the pulmonary veins. This is the commonest, 70–80% of the time. And this atrial activation spreads to the atrium and causes atrial fibrillation. This is called focal, and usually this is the mechanism of paroxysmal AFib, which is comes and goes, it does not last a long time. They may have multiple re-entry circuits in the atrium, and this is commonly with dilated atrium. It can cause sustained atrial fibrillation, so atrial fibrillation lasts for a longer period of time. So it could be focal activation, then abnormal spread in the atrium causing fibrillation, or it could be multiple re-entry circuits in the atrium, and this is the common. There are other mechanisms here, but we don't need to go over them. Okay, what are the causes of atrial fibrillation? So why this patient goes into atrial fibrillation and not other patients? What are the common causes of atrial fibrillation? Age,
Hypertension.
hypertension,
Coronary artery.
ischemic heart disease,
Tachycardia in general.
Mitral stenosis,
valve disease,
electrolyte imbalances.
electrolyte imbalances, excellent.
COPD.
Lung diseases, usually for better, but can't just go to atrial fibrillation. So to remember it actually, this is, we know atrial fibrillation is disease of the heart, right? So it could be cardiac diseases, pulmonary diseases, systematic diseases, others. Any cardiac disease, just name it, anything you think in your mind, hypertension, cardiomyopathy, valve disease, pericarditis, myocarditis, any cardiac disease can be predisposed to atrial fibrillation. Second, in the lung, 2 conditions, pneumonia or pulmonary embolism. So sometimes they come with pneumonia and different atrial fibrillation. We see it commonly in the ER. Once you treat the infection, it goes back to normal. So pulmonary embolism, pneumonia. Others think about 2 conditions because it's common: thyrotoxicosis and sepsis. And then, of course, we have electrolyte disturbances and others, which is explained already. But just remember atrial fibrillation, cardiac, so cardiac causes, any cardiac disease, lung, pneumonia, pulmonary embolism, systematic thyrotoxicosis, sepsis, and others. How to manage? Just outline of the management. So first of all, think about prevention of thromboembolism. Not every patient with AFib has the same risk. So we usually differentiate between valvular and non-valvular. And for non-valvular, we have Chad-FASCO score. We don't need to know it for now, but know if there is risk score. If they are high risk, we anticoagulate them. If they are not high risk, maybe no need for anticoagulation. So it depends on the risk. Not every patient has the same risk of stroke. Second, the fast ventricular rate, we can control it with strategy called rate control. So the patient stays in AFib, but just we slow down the conduction down the AV node by giving beta blocker, calcium channel blocker, or digoxin. We can combine beta with digoxin or calcium channel blocker with digoxin to slow down the rate. So the patient is still in AFib, but we slow them down the rate. And this is by the way the initial strategy. When they come, we just slow them down. They may convert by themselves.
But it's just slow down the conduction. There's still that very
But
high.
fibrillation is there. That's why we call it just rate control, but not
So they would have still a high risk of coagulation thrombosis formation.
yeah, exactly. By the way, two strategies. This is separate because even if you use rhythm control strategy, we still anticoagulate the patient because it's not effective 100%. You can go to AFib anytime. Rhythm control. So we said, okay, we'll not keep the patient in atrial fibrillation. We convert him to sinus rhythm. We can try different strategies. One is antiarrhythmic medications like IV amiodarone, IV epitolide, or shock the patient, sedate the patient, cardiovert him to sinus rhythm by electricity, or consider AV study and catheter ablation as last resort. Rhythm or rate depends on the patient age, depends on risk factors, depends on many things, and most of the time we start rate control and then go to rhythm control as needed. This is just explaining the same thing for rate and rhythm control, so I'll skip it. Now, next patient, 50 years old with valve. Excellent. So everybody recognize that. By the way, it may look wide, but if you look carefully, it is not more than 3. So that's why sometimes when you enlarge it, it looks bigger. But actually, if you look carefully, it's corresponds to this than 3. And it is regular, but you see the sort of appearance of flutter way. So we are dealing with flutter, atrial flutter. Atrial flutter is a large entry circuit, most of the time in the right atrium. The rate in the atrium is between 250 to 350 beats per minute. However, the conduction down the AV node could be fast, could be slow, could be regular, could be irregular. You will hear this terminology. You don't need even to remember these things, but the circuit in the right atrium could be this way. Is this clockwise or counterclockwise? Counterclockwise. And or could be clockwise, dependent on the isthmus between the tricuspid valve and the IVC. This is actually, if you cut the heart this way, this is the tricuspid valve, this is the mitral valve. They are facing each. So it could go this way, this is counterclock, or this way clockwise. It produces different ECG morphologies. You don't need to remember them, but just remember it could be counterclock or clockwise. This is the common atrial flutter. Sometimes it could be uncommon atrial flutter. If it is in the left atrium, if it happens in the lower atrium instead of that circuit, or in the upper atrium, this is called atypical flutter, different type. Management, the same as atrial fibrillation. Think about anticoagulation as indicated based on the patient risk. You may just rate control the patient or rhythm control the patient. And sometimes actually we move from one strategy to another. So we just try rate control, patient is symptomatic, not improving, we go for rhythm control. We may start rhythm control, try to keep him in sinus rhythm, we go back again to flutter all the time, then we think, okay, just go back to rate control. But if the rhythm control is catheter ablation, it's very successful in typical atrial flutter. So again, we consider it early for atrial flutter. So two conditions with, could be irregular. Atrial fibrillation always irregular. Atrial flutter could be regular, could be irregular. What is this name? 60-year-old male with COPD. What do you notice here? There is tachycardia, right?
Yes.
Okay. Is it narrow or wide?
No.
Regular or irregular?
Irregular.
Irregular, excellent. Is there a P wave? And actually they are helping
Yes.
you with this arrows.
Yes.
So there are P waves. But what is the main thing about these P waves?
There's a variety. There's a variety.
One is negative, one is positive,
Right.
third one is in between. So we have different P wave morphologies. And of course, because of different P wave, the PR also could be different. So what is telling you that this atrium is coming, the activity is coming from the atrium, but not from one area of the atrium. Sometimes from right atrium, sometimes from left atrium, sometimes from upper atrium, sometimes from lower atrium. What is called this condition? Multifocal atrial tachycardia. It is rare, not common. But if you see irregular rhythm and you still see P waves in between three different morphologies, then you think about multifocal atrial tachycardia. For multifocal atrial tachycardia, the main management is to treat the underlying cause. Just treat hypoxia, which is the main predisposing factor, and treat the underlying cause.
Which lead should we focus on?
Or rhythm lead 2. Then we look for other leads. But lead 2 is the most important for looking stuff. So it can happen with COPD, aminophylline use, sometimes any underlying cardiopulmonary disease, treat the underlying disease, and they will improve. So far we discussed neurokerus complex regular, sinus tachycardia, SVTs mainly. Atrial flutter could be regular. We discussed the three differential diagnoses of irregular supraventricular rhythm, atrial fibrillation, atrial flutter, and MAT, multifocal atrial tachycardia. MAT is rare, so we just concentrate on flutter and fibrillation. Now we are moved to something else. What do you think of this kerus complex?
Irregular.
It is wide.
Oh, wide.
So there is tachycardia.
Yeah.
Kerus complex is wide. Regular or irregular?
Regular.
Regular. Do you see clear P wave?
No.
No clear P wave.
VT.
So we are dealing with
Ventricular.
tachycardia. It's very important to recognize. Is it monomorphic or polymorphic? Morphology is the same. So it is coming from one source. So this is monomorphic ventricular tachycardia. So again, monomorphic, same morphology. Polymorphic, it is ventricular tachycardia, but kerus complex morphology is changing. What is this? Yeah, polymorphic and torsade. Polymorphic and then torsade. Torsade is a special form of polymorphic ventricular tachycardia when they have long QT as a baseline disease. So to remember, this one is not important. So for ventricular tachycardia, the commonest cause of wide kerus complex tachycardia is a VT. That's why we say number 1, number 2, number 3 is a VT, then rule out other causes. It could be due to triggered activity or abnormal automaticity or re-entry in the ventricle. So patients with old infarction in the ventricle, scar tissue, areas of normal conduction, areas of slow conduction, BBC comes in state of re-entry in the ventricle, it can cause ventricular tachycardia. This is the commonest, by the way. Re-entry is the commonest. This is less likely to be the cause of it. They may be hemodynamically stable or unstable. We discussed already how to manage stable or unstable patients totally in the First prognosis depends on the presence or absence of structural heart disease. We have ventricular tachycardia in normal heart. Usually prognosis is good. Ventricular tachycardia in abnormal heart, like patient with ischemic heart disease, cardiomyopathy, it's worse prognosis. So they are not the same, by the way. If the heart is normal, prognosis is good. If the heart is abnormal, prognosis is bad. The causes of VT could be coronary artery disease, the commonest, cardiomyopathy with its different types, valvular disease, congenital heart disease, electrolyte abnormalities, and sometimes could be idiopathic. There is no clear reason for the ventricular tachycardia. Okay so far? Okay. So with the ventricular tachycardia, the rate is very fast. Sometimes it can, of course, the atrial flutter is not there because the ventricle is a driving force, and it can affect the cardiac output significantly, especially in patients with pre-existing vascular disease. Sometimes it can degenerate into ventricular fibrillation, so that's why we treat it as emergency. Even if the patient is hemodynamically stable, at any point may move from ventricular tachycardia to ventricular fibrillation and then they arrest. So we have to treat it aggressively. Monomorphic just indicate that it is coming from one source. I showed you there. You don't need too much about this. Polymorphic, different morphologies. One part of it is the torsade. I showed you example of torsade, and this is special condition when the patient has long QT, which could be congenital, long QT, or acquired, like medications causing long QT, electrolyte problems causing long QT, then they develop polymorphic region. So, what is the differential diagnosis of white Carus complex? Number one, we said ventricular tachycardia, and everybody agreed this is number one. And 80% of the time will be right just by anticipating. But remember, there is other differential diagnosis.
Bundle branch.
Yeah, bundle branch block. If somebody has left bundle at the baseline, or right bundle at the baseline, he has left bundle all the time, or right bundle. Any tachycardia will develop with a sinus tachycardia, SVT, atrial fibrillation, irregular flutter. The difference would be irregularity. It will be wide because his baseline ECG is wide, right? So one of it is SVT with bundle branch block. Second, some people actually when they prostrate, functionally, they're bundle blocks, functional block of the bundle. Got refractory with a right bundle or left bundle. This is again SVT with apparency due to bundle branch block. So it could be pre-existing bundle branch block or functional bundle branch block during the tachycardia. The third, remember when we discussed antidromic? It goes down the accessory pathway, up the AV node. Down the accessory pathway, up the. So this is another white Carus complex tachycardia. Pacemakers, when we have a pacemaker, usually we put the lead where? In which area of the heart?
Sorry?
The pacemaker. Pacemaker usually for ventricle, we put it in the right ventricle, right? So if the pacemaker is acting, it will act white Carus complex. It will produce white Carus complex. So what is the differential? So don't worry about the pacemaker because you will see example, inshallah. By the way, in the final year, I will discuss more about the pacemaker and more about management of pacemaker, inshallah. Metabolic disorders like hyperkalemia can cause white Carus complex. And sometimes medications, remember, antiarrhythmics sometimes cause white Carus complex. And if the patient has tachycardia, it will look like very white Carus complex. So this is just differential diagnosis. How about this one? Ventricular fibrillation. Chaotic, disorganized, there is no clear P wave, no clear Carus complexes. So ventricular fibrillation. It is called shockable rhythm because if you shock the patient, you can convert him to normal. So it's very important to recognize it. It impairs the cardiac output, so you really have to manage immediately. And after managing, you look to the underlying cardiac disease. Why did they have the ventricular fibrillation? Most of the time, they will end up needing a defibrillator. So, what causes ventricular fibrillation? The same causes for ventricular tachycardia. All the causes I mentioned earlier. Add to it some diseases that the heart is normal, but they can have it. There is a syndrome called Brugada syndrome, long QT syndrome, pulmonary embolism, extracardia, electrolyte problems. If it is severe, it can cause fever. Don't worry about the differential, just concentrate on the common causes of the ventricular fibrillation. So if the patient has tachycardia, look, it is narrow or wide, right? If it is narrow, regular or irregular. If it is regular, sinus tachycardia, SVT. These are the two things you should keep in mind. If it is irregular, three differential diagnoses. Atrial fibrillation, atrial flutter with variable conduction, multifocal atrial tachycardia. And we've seen ECGs of all these three, so remember them. If it is wide, again, could be regular, could be irregular. If it is regular, number one is what? VT, ventricular tachycardia is the commonest thing. Antidromic tachycardia is another differential. Any supraventricular tachycardia with apparency with bundle branch block will look wide and regular. Irregular, very limited, polymorphic VT. Very rarely supraventricular tachycardia with apparency but with variable conduction. For example, atrial tachycardia, the rate is 200. Some patients they cannot conduct this 200 and they have bundle block at the equilibrium, so they may conduct 2 to 1 or 3 to 1. Flutter with or fibrillation with bundle branch block at the beginning, it will be irregular. These two conditions here, for now, we just concentrate on the first two diagnoses: ventricular tachycardia, polymorphic VT, and VF, of course. Don't worry about the others, but keep it in mind. Okay. Excellent. Thank you very much. If you have any question, we can go.